How you guys doing? So I'm just going to give a quick brief intro to Dr. Mata. She's currently a PGY3 at the University of Miami in physical medicine and rehabilitation. Her professional interests include interventional pain and neuromodulation. For her, training in Miami means caring for a diverse patient population, and one of her passions is in medicine is languages. So we're happy to have her today for that. She strongly believes that we can positively impact healthcare by increasing physician access to cultural resources, offering medical Spanish, and spreading awareness of other cultures. So the floor is yours, Dr. Mata. Thank you for being here with us today.
Thanks for having me, Dr. Luisa and Lucila. So tonight's topic is comprehensive workup of low back pain. And I do want to say thanks to the people that have tuned in, Spanish speakers and not, because I think that's amazing that you want to continue developing your skills to give better patient care, be more efficient, and make sure you're getting the whole story. So I think that's awesome. Okay, so just to give you a quick brief overview of what you're in for, I'll go over the objectives of what we're gonna touch on tonight, and then go over some basic anatomic terminology that you kind of need to know so you can clue in on okay, what are they trying to tell me? 3, I'm going to go over the basic workup of low back pain. We won't have time to cover everything because that's a really large subject, but at least the most common things and how to diagnose that. And then 4, los puntos salientes, or the salient points. So basically your high yield takeaways. If there's anything you want to take away from this lecture, I've condensed the most important things into a couple of slides. Feel free to screenshot or reference the recording after this. Okay. So number 1, I want you to be able to identify basic regions in the body so that when you're speaking with patients, you can ask about them and understand when they say them to you. 2, essential phrases for your HPI. I've specifically distilled this for low back pain so that when you're giving a presentation to an attending, these are the things that they're going to care about and that are going to drive your differential one way or another. We're going to go over a quick top 4, top 5 pain generators by body area to kind of give you a good differential to start with. And then we're going to go over the most high yield physical exam maneuvers. I've chosen those that are most sensitive and most specific for the region. So you can hone your diagnosis and say, this is what it sounds like. Does it match that on physical exam? And then finally, I'm going to give you a couple of phrases, basic phrases to help you position your patient during your physical exam. So starting with basic anatomy. Oh, might be a bit of a lag. Yeah. ¿Dónde le duele? So where does it hurt, right? So obviously everybody knows the word dolor, and I've seen the videos of a patient conduct, or a student doing an entire exam with just the word dolor. It's great. It can get you through in a pinch. I think some of the things that I hear, especially being in Miami from co-residents or even attendings who don't speak Spanish, is it's a great question, but it can also open up a can of worms. People might start telling you their full life story in Spanish, and you're like, whoa, I didn't want all that. I just wanted to know literally where is your pain. So I think a better question, even for native Spanish speakers, is apunta con el dedo. So literally asking them to point with their finger. Because even if they can't point with their finger, that tells you valuable information. So starting by region, just for completion's sake, I included the neck. So dividing our spine into C-spine, T-spine, L-spine, and other extremities. Cuello. So that's obviously the word for neck. I'll give you some mnemonics, whether they're helpful or not, or just different ways to think about how to remember cuello. Espalda, everybody knows, means back, but it's really non-specific. It's upper, middle, or possibly even lower back. Lumbar, just like lumbar, a lot of different Hispanic cultures recognize lumbar if you say that word correctly, right? Not as lumbar, but lumbar, referring to the low back. Cadera for hip, whether that's the front of the hip, osteoarthritis, versus the back of the hip. And then finally, pierna, right? So meaning their leg. So it's really important to kind of figure out which of these is the main regions that your patient's experiencing pain. And then starting with your neck, so you can think about popping a collar, right? Your collar. So again, repetition is key for learning languages. Apunta con el dedo, donde le duele el cuello. So it's coming from the Latin word column. If you think about collar, you're pretty much halfway there. So think of the word collar. And then just remember that whenever you see a double L in Spanish, it means a Y, right? So collar or cuello. One way that I've kind of worked with some of my attendings, those who come from Chicago specifically, who have difficulty pronouncing Spanish words, is if you really have no idea how to pronounce the word, break it down into 2 syllables at a time. Chances are that you're going to be pretty close with your pronunciation. So in this instance, cuello, cuello. So if that's helpful to think about it that way, that's one way to think about it. Next up, we have espalda and lumbar. These are pretty straightforward. Again, it's going to be kind of the same thinking of like splitting it up into 2 words. Espalda, lumbar. Only thing you really need to remember is that it's not lumbar, it's lumbar. So the O kind of sound with 2 U's. And then cadera, if you want a way to remember this, think about the sit bones, sitting in a chair, cadera. Kind of cheesy, but whatever works for you. Sometimes I like to think of ways that languages are similar to things I already know, just to make it easier to remember. And again, apunta con el dedo. If there's one thing that you take away from this lecture, I really hope it's that. Even in English, point with 1 finger and show me where it hurts. Pierna, apunta con el dedo, te muestran la pierna. Similar to the word for foot, pie, just another way of possibly reminding it. Most people know pie, so pierna. Okay, so what do you do if you've asked them a bunch of times and they really don't know and they're just doing this dance and everything hurts? So in Portuguese, we call it o baile todo. That's actually a joke. It's a reference to an old song. If you get it, you get it. If you don't, you don't. Pero me duele todo. Everything hurts. Okay, that's helpful too, right? So you don't fall into one of those other buckets, but everything hurts. That also kind of tells me what I can work on. So some things I want you to remember, if they start speaking at you and you're like, oh, this is great, this is so many things, just stay calm and redirect. That this also is incredibly helpful in English as well. When a patient's coming at you with so much information, stay calm, smile, redirect. A lot of times people come in with back pain or other pains, and maybe there's a lot of things going on there. Maybe they have low back pain and SI joint pain. Maybe they have myofascial strain and facetogenic arthritis, and they have a radiculopathy. You won't necessarily treat all the problems on one visit. You just need to find the biggest problem. And that's where the word más comes into play. So just like in English, first thing you want to do, characterize the pain. So specific event or gradual, right? Chronicity. You want to establish that because that's going to help narrow down your differential. Location, ¿qué le duele más? So if they're giving you multiple regions, then you can just say the most. What hurts the most? And we're going to work on that today. Duration, you just want to characterize it into days, months, and years. Again, establishing chronicity. And then the character. I'm going to give you 3 words to kind of just that you can give them, because a lot of times patients have trouble describing their pain. It's, it's one of these 3 things. Pick the one that most resembles what you have going on. And then alleviating, aggravating could be a lot of things, but I think if you had to pick one question specifically in low back pain, does it improve with rest? Because if it doesn't, that kind of pushes you towards like more acute things that need to be seen more urgently versus things that have been going on for a while and probably, don't need urgent attention. Radiation, that's pretty straightforward. Does it travel, right, to the leg or the hip? And then timing, if you had to make it very simple for someone, always or sometimes. It's either always there or it comes and goes. And then severity, scale of 1 to 10. And then once you have an idea with what kind of pain they're dealing with, you want to get your pretest probability, or you want to put a frame around the pain. So give a little bit of context, kind of tell them, just like if you were presenting a patient with acute coronary syndrome, if they have risk factors, that needs to be part of your presentation. Same thing with low back pain, right? Are they diabetic and they're coming in complaining of leg pain? Okay, so maybe it's not a radiculopathy, maybe it's more like a diabetic peripheral neuropathy. Do they have a history of cancer and they're coming in with low back pain? That's important to know. Or do they have some sort of autoimmune condition and they're on chronic steroids? That bumps other things higher up on the differential. Surgical history. So if they're coming into you with some type of back, hip, or knee surgery proceeding, that can definitely take a role. Any pain medications they're taking at home and give them an example, that helps. Because if it's responding to Tylenol or Advil, that kind of gives you a clue. It's probably not nerve pain, right? Expecting something stronger for that. And then finally, is their job something physically repetitive? That's going to put them more at risk for chronic conditions like arthritis. Okay. So characterizing the pain, these are just some phrases that I've distilled down that feel free at the end. This will also be here again to take a screenshot. And I've included the accents. Accents are your friends. They will always tell you what part of the word you need to stress a little bit. So when did it start is a quick way to say it. ¿Cuándo empezó? And if it's something that they're like saying, oof, you're really failing to understand, what they're trying to say, you can use the third question to help you. So, ¿qué le duele más? We talked about that if there's several options. But if you ask them cuándo empezó, and they're coming with an answer that has more than you can process, you can break it down into this next question: días, meses, or años, right? So you just want to know, has this been going on for days, weeks, or months to establish chronicity? So that's a really good question to kind of help redirect. And then for one word, the 3 words I've offered that you can like give them as an example is quema, does it burn? Aprieta, is it something that's tightness, right? Like a little bit maybe more muscular versus like a nerve pain? Or punzante, is it a sharp pain? Which can kind of be something in between. Alleviating and aggravating, again, my number 1 question would be, does it get better with rest? Mejora con descanso. And then radiation, I put this is not the most eloquent way to state this, but I put it in a way that anybody could understand regardless of education level. El dolor se queda ahí o se mueve. Remember the 2 L's equal a Y. So when in doubt, Google Translate and hit the little speaker button. And then always or sometimes. I just ask, do you always feel it? Siempre lo siente? If the answer is no, that's all I need to know. If the answer is no, that's it. And then finally, de 1 a 10, 10 siendo lo peor, ¿cuánto le duele? So again, from 1 to 10, but always establish that 10 is the worst. How much does it hurt? If you're interested in using these phrases, it'll be at the end of the PowerPoint. Feel free to take a screenshot. And then medical history is pretty easy. It's a lot of things revolving the word historia. Do you have a history of? ¿Tiene historia de diabetes, cáncer, o alguna condición autoinmune? So I included the phonetic spelling here because if you just say autoimmune, it sounds nothing like autoimmune. So it helps to be able to pronounce the words, because sometimes you're saying the right word, but just not with the right pronunciation, and it may not get across. Se ha operado de la espalda, las caderas, o las rodillas. Again, double L's are your friends, and you know most of these words with the exception of rodillas, and that one's a little bit more straightforward. And you might also find that information in their chart. And then this one has always been helpful for me. Algún medicamento ayuda, and I always give examples because people don't know, right? So some people may know acetaminophen because in a lot of Hispanic countries, you go to the pharmacist and they will tell you what you need to take, and it's a lot easier to get medications. Or you can just say Tylenol. I would give a couple of examples of things you find over the counter and see if they respond to that. And then finally, just ask what their job is. So, ¿cuál es su trabajo? Because that can give you a clue. Okay, so now we're going to go into diagnosis. Before we go into the body regions, one thing that I will say that time and time again has been like the biggest pearl: trust but verify. So verify the structure and location. I can't tell you how many times people come into clinic and say, oh, my low back is hurting. And then you do an exam and it's not their low back at all. It's their PSIS, it's their SI joint, it's their greater trochanter, it's their glute medius. It's another structure that is not their low back. So have them point with their finger, and then you go and use your anatomic landmarks to find out if that is actually the structure. And then if they say in the leg, you need to know where in the leg. Does it go past the knee, or is there pain all the way into the foot? And if so, what part of the foot? So again, your dermatomal map, whether you're thinking radiculopathy or like, is this a referred pain from something else? Okay, so why am I covering what I chose to cover with my differential diagnosis? So common things are common. Among patients who come in with back pain, less than 1% are going to have a serious etiology, like a cauda equina, a metastatic cancer, or a spinal infection. So unless you're in the ER, and even if you are, definitely think of these things first because they're pretty common. So starting with our back, right? By far, muscular strain or myofascial pain is incredibly common. You can have really tight muscles that can cause severe pain or even sciatica-like symptoms that people would swear that they've got a herniated disc that's causing it. And maybe they do have a herniated disc, but they also have muscular strain that is so intense that it seems like they're having something more serious than they are. Spondylosis, any type of degeneration, regardless of the structure, I've listed them here. Spondylolisthesis, definitely something important to check for when you're getting your x-rays. Compression fracture, and then radiculopathy. A lot of people put radiculopathy under the back. I don't think of it that way when it comes to like seeing patients. I think of it under the leg, and we'll talk about why again in a second. So again, musculoskeletal causes of back pain. If you just look at, if you've ever been to like the Human Body Museum and think of how many layers of muscle is on the body and that it's all innervated and the connective tissue is innervated and it's connected through the connective tissue. So it's kind of like a chain sharing all that tension. It's crazy. There's so many structures, whether you're doing ultrasound or fluoroscopy, you will never run out of muscular injection points. So really think about that. If you take away that top layer that you just saw, I'm going to kind of go through this like a little bit of a book and just point out some high yield muscles that you can check for on your exam and like things that I'm looking for on a physical exam. So number one, always start with the iliac crest, especially if you have a patient that's really like obese or like really tall, because a lot of times it's way higher than you would think it is. So they're pointing at a spot and you're like, oh, you know, that's probably, you know, you're down by your hips or your low back. And then you verify and you're like, oh, your hips are actually way up here. Your length is from your legs, not from your torso, or vice versa. So I always find that iliac crest, and then I follow that ridge to know where I am in the person. Lat dorsi, right? So they've cut it. You saw it on the previous side. It's pretty big and it's pretty thick, but notice that it's inserting into the fascia, as well as the trapezius, and just notice like how that this thoracolumbar fascia covers so much, and it's contiguous with a lot of the tendons of the musculature in the back. So it can hold a lot of tension until it can't. If you're rolling your finger down the spinous process of your patient, which you should, to look for like a little bit of scoliosis, always screen for that. If it's not greater than 10 degrees, it's technically not scoliosis, but just to have an idea, is their spine straight, or do they have, you know, lateral curvature in their spine that could be predisposing them to have other conditions? If you go off to the side and you feel like those big ropey muscles, that's our postural muscles, right? Our I love spaghetti, our iliocostalis, longissimus, and spinalis. That kind of clues you in if they're having pain in those regions. Yeah, it would respond to trigger point injection, but they're having postural issues that need to be looked at. And then if you go a little bit deeper, my favorite muscle and yours, the transversus abdominis, it's what is being triggered when it's what people are working on when we send them to PT most of the time. It's one of your deeper core muscles. It's also connects into the pelvic bones, contiguous with the fascia of the pelvic floor musculature. And as you'll see here, also with our lumbar and supporting our internal organs. So it's incredibly important to strengthen. You'll see it on the next slide, inserting to the thoracolumbar fascia. And then our even smaller like musculature that supports the spine, like our interspinal muscles, our QL, our quadratus lumborum, it's my spirit muscle. It's the antagonist muscle of the psoas. So a lot of people who have really weak hip flexors because they're spending all day like sitting in chairs at desk jobs, and they're spending a lot of time trying to be extended, that muscle a lot of times gets overworked and goes into overdrive. So they have a lot of pain kind of starting at their hip. You see it starts at the iliac crest, and then it inserts along the TPs of the lumbars, and then it runs up to the 12th rib. That's really tense in a lot of people. And sometimes that when people say my back is out, it's just their QLs are in a spasm, and it's super painful. So trigger point muscle relaxants help a lot. And then you can see some of our smaller spine stabilizers here. And then finally, you get to that little square that was always cut out on the cadaver at the end of the test, the multifidus muscle. But look how big this guy is. And he starts all the way at the bottom of the sacrum, inserts on the, originates also in the PSIS, and runs all the way up the spine. So there's a lot of muscles that could be potentially causing your patient's pain. So all I want you to remember is that just because a patient has pain at a bony landmark like the PSIS, that doesn't necessarily mean it's that bone or that joint. It could also be, diseased tendon, whether that's like acute or chronic of a muscle tendon, enthesopathy, where it originates or inserts at that site. So kind of broaden your differential a little bit and be like, yeah, this could be SI joint pain, or it could be, multifidi, or it could be iliac crest pain. Maybe they have some sort of enthesopathy of the QL or the glute muscles there, just to kind of think of that. And then again, always use your landmarks on patients, never eyeball it. Go to the iliac crest, walk immediately to L4, move up and down so you know where you are. If you can't find the PSIS, walk on that crest until it curves down into the PSIS, and then fall in medially so you can get that SI joint where it hugs the sacrum. And your question that you're asking your patient for all of this is, duele cuando toco. And if you don't want to say all that, you can just say, duele. It's a little bit better than dolor. You're just that much better than someone who didn't come to this lecture tonight. All right, degenerative diseases. So this one, we joke around and we call it la enfermedad del calendario. It is a disease of the calendar, because as the years pass by, things start breaking down, and this is what you get. So this is a healthy joint. You see your vertebral bodies. We have our discs, right? We have our squishy water proteoglycan nucleus pulposus in the center, surrounded by our collagenous annulus fibrosis that's holding it in. This is a nice, healthy person, so it's really hydrated. And here you see just another view of that inner zone and outer zone. And then you can see some of our bony processes in the middle of the foramen where the spinal cord lies. And just one more view to see that there is a little bit of hyaline cartilage that's on top of that vertebral body. So it's kind of think of it like a knee, and the disc is a meniscus, right? So what happens when we have spondylosis? Everybody has spondylosis as they get older to some degree. Basically, that disc loses hydration and it loses a little bit of elasticity. It's less likely to be shock absorbent and just get blown out. Slowly but surely. So you have a thinning disc, and then that puts more pressure on the bones. Wolff's Law, anytime you put pressure on a bone, you're going to cause it to grow. And that's how you get those bone spurs. Further proof as if you needed it, although we don't need an MRI to diagnose degenerative joint disease in the spine. Here you see those unhealthy discs. They're pretty, dark in color. They're desiccated. They're using that water. So another thing I want to point out, other structures here, notice that the normal curvature of the spine is kind of like a C, right? Like a and reverse C. Let's think about it that way. Some of the structures that help take up the slack when that disc gets thinned and now that curve is exaggerated are these facet joints in the back here. The more extension you put on them, the more you're grinding those joints together. And they do their best, but they can only do so much. So you can have facet joint osteoarthritis, and we'll talk about how specifically to diagnose that. It matters because there's specific injections we can do for those joints that help that pain, different than just like generalized arthritis of the spine that we talked about before. So you can see how bad it gets. In the top picture in A, that's pretty normal. B, you're starting to get a little bit of edema and that space is closing. C, you've got osteophytes. And then D, that doesn't even look the same anymore. And you can kind of see this too on the axial view and how that can also impinge on the core. So the biggest test for this is going to be Kemp's test, quadrant test, or facet loading. So basically you're just overextending those facet joints as much as you can. You're rotating and you're side bending to whatever side you're testing, the right or the left, to really grind them as much as possible. So I always let my patients know, voy a examinarle, I'm going to examine you. And that way they're kind of open to positioning. The only thing that I ask them to do before starting this is to look up at the ceiling to help with that extension. And then once I move them, I can always exaggerate it. So again, reproduction, a positive test is reproduction to that same area that they pointed. It usually should be by the TPs, the transverse processes. So mire hacia el techo, look up to the ceiling. And then you can always ask, if you want to say duele, there's nothing wrong with that. But if you want to be a little bit fancier and sprinkle some pizzazz on your español, you can say, eso le produjo dolor. Did that produce pain? So again, all this will be at the end of the slide if you want to take a screenshot of the phrases. So moving on, I'm just going to briefly touch on the other types of arthritic pains that you can have. So vertebrogenic and discogenic, it's definitely something that we look into in the pain world, more so when they have axial non-surgical low back pain that's failed to respond to conservative measures, and they're negative on a lot of these other tests and like imaging aside from other findings. If you want to think about that, basically the easiest way, and this is how surgery thinks about the spine, anterior, middle, and posterior column. And if we want to make it even simpler that we could explain it to a 5-year-old, if you flex forward, you scrunch all the things in the anterior column. So vertebral bodies, discs, things like that, right? So if somebody is having more pain being flexed forward, think about structures in the anterior column. Versus in the posterior column, we've got like our facet joints, possibly ligaments, but more so facet joints. If they're having more pain with extension, you want to think about things in the posterior column. And never forget spondylolisthesis. Whenever you're going to get that x-ray, you're like, oh, I think this person just has arthritis. Always get AP and laterals, flexion and extension, because you never know when there's some spondylolisthesis. If it's a grade 1 and it's stable, meaning it doesn't really move that much when they flex and extend, that's fine. But if it's not stable and it's more than that, like a grade 2 with instability, then they really need to be seen by a surgeon, and that needs to be fixated to prevent spinal cord injury. And for this, for having them scrunch forward and test things in the anterior column, toque sus pies, touch your feet. Pretty simple, but you can get a lot out of just that one phrase. Compression fracture. This is pretty straightforward. People who have long-term corticosteroid use likely have lower bone density. And these are some of the most rewarding patients to treat, because you'll come in, they'll have pinpoint pain at one spot that started all of a sudden. And it's on a bony landmark. Usually it's over the spinous process or the TPs. They're in excruciating pain. They're great candidates most of the time for kyphoplasty. And as soon as they get off the table, they want to hug you because their pain is so improved. So don't forget to ask about steroids because you don't want to miss a compression fracture. That's a home run if you find that. And then radiculopathy. I told you that I don't necessarily think about that in the back bucket. Yes, it does live in the back. Here we see our beautiful little pea-sized DRGs, our spinal ganglion. The reason I don't think about it in the back is because no matter what is pushing on that DRG that is irritating it, or even if it was pushing on the motor nerve and causing symptoms, those symptoms are going to be along the path of that nerve, which very quickly leaves the back and descends. So it's going to be in that leg or dermatomal distribution that they're coming in and complaining about the pain, not necessarily the back. They may have back spasms in conjunction with the radiculopathy, but normally the leg, that like searing pain, is what's worse, especially in a radiculitis. Okay, moving on to the hip. My favorite and yours, sacroiliac joint dysfunction, incredibly common, incredibly underdiagnosed, especially with low back pain. There's a lot of overlap. And I think a lot of that comes from physicians and other specialties kind of take you at your word. Again, if you say like, I have low back pain, they're like, oh, they have low back pain. It may not be low back pain. If they're telling you things, if you're not asking questions like, hey, is it worse when you rise from seated to standing? That's a very like classic SI joint dysfunction part. OA of the hip, also very common. Avascular necrosis of the hip can be common depending on the patient, but if you're not thinking of it, you won't necessarily catch it unless the radiologist calls it when you get your plain films. Enthesiopathy and impingement, again, very common, especially if you're dealing with like enthesiopathy, more so with like a really active younger patient population or an older population. Like glute medius tears in older females is like a dime a dozen. It's very common. Impingement can also be important. Just for time's sake, I'm not going to go too in depth on those, but those are important differentials to be aware for the hip. So sacroiliac. Showing patients the sacroiliac joint is also helpful in explaining their pain, because they may be just so convinced that it's the low back, but explaining to them, yeah, there's a joint in the front of your hip, but there's also a pseudo joint in the back. And SI joint dysfunction is a catch-all term. So whether they have too much mobility, right, their ligaments are too lax, or they have too little mobility at the SI joint, that can cause pain. And then also arthritis, less likely, but obviously sacroiliitis. So unless someone has a spondyloarthropathy, like a negative spondyloarthropathy, we don't call it sacroiliitis, right? It's generally just sacroiliac joint dysfunction. And then if they have findings that are consistent with arthritis on X-ray or CT or whatever other imaging they have, then you can say sacroiliac joint dysfunction or degenerative sacroiliac joint. This one can be a tricky one though, because it can refer down, right? And kind of like those sciatica-like syndromes, we'll talk about it later. But this kind of is what makes pain, I think, rewarding, because you really have to think about it. It's not always cut and dry. Disc pain can radiate to the back of the knee or a little bit further. So can facet pain, generally stays above the knee. SI joint pain can go all the way down to the foot. It usually doesn't, it usually stops by the knee, but it can go all the way down to the foot. And if you have more anterior SI joint pain, it could radiate to the groin. And you might be thinking, oh, is this OA? So you really have to take imaging, history, and physical exam and kind of blend it all together and be like, now what do you think is causing this? There are tests. This could be in and of itself. But basically, for insurance purposes, if you're going to do an intervention and to increase sensitivity and specificity, you should get at least 3 out of 5. These aren't all of the tests that you do. But again, just like any test in medicine, we're trying to recreate the problem. So I'm going to jump on your SI joint and see if it hurts. I'm going to pull it apart in the front so it's squishing together in the back, aka distraction. I'm going to compress it together from one side. I'm going to push the hip on the SI joint and see if that hurts. I'm going to push your thigh into your hip and thrust it in the back and see if that hurts. I'm going to try to push your hip all the way forward while your sacrum stays forward on the table and see if that hurts. And then Faber's externally rotate, push that hip and that sacrum together again. So 3 out of 5 is what you need for insurance. You need to know how to do those tests. All your patient needs to know how to do is to lie face up on the table. So I always think it's funny when people ask like face up or face down. I think they should normally assume face up, but they don't. So you just need to remember boca arriba, mouth up. Acuéstese boca arriba. If you really want to be fancy, you can use all the words. Otherwise, you can just say boca arriba and they will know what you're saying. Osteoarthritis. So super common, C sign. A lot of times people will give you a C sign, but a lot of times they won't. So just going over the findings, you kind of already know what that is. So radiographic findings, it's not really a clinical diagnosis. You can have suspicion, but you need radiographic findings to definitively say that. That narrow joint space from loss of cartilage, you can see those bone spurs. Ultimately, people generally end up in hip replacement. You can stave it off with corticosteroid injections and some physical therapy they should definitely do to strengthen the surrounding musculature, but only the patient can decide when enough is enough and they really need a hip replacement. For this, a great quick and dirty is Fadir and Faber, right? So Fadir is definitely more sensitive because that's more pain with internal rotation. So both of these tests, figure 4 and then crossing the 4 over the leg. Only thing you need to know is le duele adelante o detrás. So hurting in the front or in the back. And then that leads us into avascular necrosis of the hip. Things I want you to think about are the S's. So somebody who's been on systemic steroids has a significantly higher chance of losing blood supply to the head of the femur and then having subsequent collapse. If they're on steroids and statins, that's even more higher risk in clinical trials. And then finally, smoking, right? Because that kills the small arteries. And that's exactly what's supplying the femoral neck. If you catch it pretty early on, generally they can just do physical therapy and surveillance to make sure that the head doesn't collapse too much. Otherwise, they need a referral to orthos so they can drill some holes in, help foster blood supply, do bone marrow graft or allograft bone transplant to prevent that. Worst case scenario, if it's too far gone, they're going to need a brand new hip. And here's some pictures just to see what that looks like. So the first, it's really hard, even though X-ray is still, according to the ACR, first line imaging, it's really hard to catch stage 1 early avascular necrosis, which is when you want to catch it, because it's just bony edema. So MRI is, if you really have a high suspicion, you really need to get the MRI. That's where you can see that edema better. If there's an osteonecrotic lesion, obviously it's more advanced, but I just wanted you to kind of see what it looks like. Basically, there's a hole and a line, parts missing in the femur, so that you can kind of notice like, oh, wow, this is really edematous. It's significantly darker. Okay, speeding along, moving into leg pain. So it's not the back, it's not the hip. They're coming in and it's pain in the leg. My first thing that I want to rule out is radiculopathy. You can, if they say 10 out of 10 and you believe them, radiculopathy should be up there. Lumbar stenosis is more of like a chronic picture. It's been going on for years and years and years. Sciatic-like syndromes, very common. That can also overlap with like muscular things. And then cauda equina, less common, but obviously always have to think about that. So starting with radiculopathy, there are several types of disc herniation. That's a whole nother lecture in itself. But the most common one, when we're talking about herniated discs that are actually causing symptoms, it's a posterolateral herniation. And that usually is affecting either the motor nerve or the sensory nerve. More often than not, it's the sensory nerve, right? So it's just that disc material that's pushing on that spinal nerve as it exits. So it's the pushing on it as it exits the leg. There have been a lot of tests. There's a lot of controversy of like, is the slump test more sensitive? Is SLR more sensitive? I'm not going to spark debates, but it's the straight leg raise. It's pretty tried and true. Starting from 0 to 35 degrees is when it's not until you hit 35 degrees that you actually start exhibiting some traction and pulling on that irritated nerve root. It's actually more specific at the lower angles, right? So if you're getting a positive straight leg test at those lower angles, like when you just start hitting 35, that's pretty good sign that you're dealing with radiculopathy. But as you go all the way up to 70 degrees, the sensitivity increases. So if there's nothing at 35, but there's something at 70, then there could still be something going on and maybe just a different level or not as bad that you're catching. So don't slack on straight leg raise. I'm still showing you the slump test. It's a great test. So technically, straight leg raise is the best test for L5S1. L4, L5 is the most common level of herniated disc, and the second place would be L5S1. Slump test is a little bit better for catching higher up. And that's because you're exhibiting traction on that nerve root from also bending the head, bending the thoracic spine above. So you're trying to stretch that nerve as much as possible. So basically for slump test, they have to have a poor posture and slump over and then try to touch their toe last. So you bring the leg up, tell them to slump, and then have them touch the toe. Again, just a quick shout out to your dermatomes because they're doing the most. I kind of already said this on our last slide, but 98% of clinically important lumbar disc herniations are L4, L5 or L5S1. So the things if you only had like 2 minutes to do an exam on somebody that you think has radiculopathy, the most important things that you need to check are weakness of the ankle, the big toe, loss of ankle reflexes, or sensory loss in the feet. So go straight to the feet. That's going to check your L5 and S1 exiting spinal nerves that could be having that disc material pushing on them. If you're going to test sensory loss, it's been clinically shown that they better differentiate pain intensity when you do pinprick. You have something sharp on you, that's going to give you a more accurate assessment of their sensation than if you're just doing light touch or dull touch. And then finally, if someone comes in and they're like, well, I have herniated disc, that may be true. And I look at your calf muscles and one is significantly smaller than your other. That's a sign of long-term radiculopathy. That's not an acute. There's nothing that I'm going to do for you at this point that is going to change long-term radiculopathy. You may have a new exacerbation of a disc at another level. But if it's already to the point of muscle wasting, that's been there for a very long time. Stenosis. So there's so many things that could be causing stenosis. There's so many different procedures depending on what it is that could fix it. But again, something structural is pushing on that nerve. Maybe it's not the herniated disc. Maybe it's that facet joint that got too osteophytic and overgrew it. Maybe it's the ligamentum flavum that's really thickened. Maybe they have congenital stenosis and it really didn't take much to push them over the edge. But again, stenosis and, well, let me go back for 1 second. Stenosis, it's most likely going to be the posterior column. So it's worse on extension if you think about the shopping cart sign. So for this one, you can also use mire hacia el techo. Sciatic-like syndromes, people come in and they go, I have sciatica. I know I have sciatica. Sciatica just means pain shooting down the leg. You don't necessarily care about that because you're here to figure out why there's pain shooting down the leg. Keep in mind, if you do that exam on the feet, they don't have weak ankles. They don't have weak big toes. The sensation is intact bilaterally to their feet, and their S1, like their Achilles reflex, is normal, but they're still telling you they have pain down the leg. You need to start thinking of these other things, right? So disc pain, I would check that back. I would do that slump test again, see if they have facet pain. I would check out that SI joint, see if any of that is painful, because look upstream if it's not downstream, to put it in a simple way. And then finally, diagnosis of exclusion, but common, well, not really that common, the piriformis syndrome as a cause of sciatica, right? So if you think about it, you have our piriformis here lying on top of our sciatic nerve. That's the case for 87% of the population, but there are people where it pierces the muscle or it straddles, and those people do have sciatica-like syndromes. I have a patient today, and he comes in like once a year and he gets a piriformis injection, and that tides him over. And he's doing pretty well with that. He's one of those people that has sciatic nerve that pierces through the piriformis. So any sort of tension on that muscle, he starts getting that pain shooting down his leg. And then finally, cauda equina. So this is rare, right? So only 1 to 2% of lumbar disc herniations. If you have to ask one question to rule it out, the most consistent and sensitive finding is urinary retention. So the question to ask your patient for that is, ¿tiene dificultad para vaciar la vejiga? Are you having difficulty emptying your bladder? If this one is a little bit more difficult to pronounce, I would just type it in and press play on the speaker, but I encourage you to practice. That would be my #1 high yield question to ask. And then part of the reason why it's rare is because it's not as common to have a central disc herniation where that extruded disc goes straight back, and it'd have to be pretty large because you have to push on all of the descending nerve fibers. So it has to be pretty significant to do that. And that's just not, like, when you do the studies, that's not the weakest part of the wall. It's usually more posterolateral and not central. And then finally, los pacientes que les duele todo, el baile todo. One joke you could make if you get really advanced is, ese es el dedo. Your pain is in your finger. It's your finger that's painful. You're pointing to all these things, but the problem is your finger. Cheesy joke, but they always laugh. So I like it. More commonly, it's a myofascial pain syndrome than fibromyalgia. I'd always be very careful to just throw out willy-nilly fibromyalgia, because that's also a diagnosis of exclusion and they have to have an extensive workup. And you never want to label somebody with that if it's not true. There's new criteria that came out to test. So if you think that's the case, then I would go through that criteria. There's also chronic fatigue syndrome if they're endorsing like profound fatigue that's like debilitating to their life. Autoimmune conditions, I'll go over some of the pearls on the next slide. And then myositis, right? So think about it. Are they on statins, or maybe there is something autoimmune, like they've got like a polymyalgia rheumatica or something else coming up? Less likely. I would first start with like a myofascial pain syndrome, but ask questions to kind of rule out these other things. Congratulations, you made it to the last high yield puntos salientes, high yield takeaways. Very proud for the 18 remaining. So quick and dirty back pain pearls. Back pain plus long-term corticosteroid use equals compression fracture until proven otherwise. Cancer. Past medical history of cancer has incredibly high specificity. So it is cancer until proven otherwise if they have a history of it, especially if they're over 50 years of age, especially if it's breast cancer or lung cancer or prostate cancer. You really need to get imaging to find out if they are no longer in remission. Ankylosing spondylitis, quick shout out to step one. Morning stiffness improves with exercise, almost always before 40 years of age. So it's a young person coming in with this kind of back pain. Autoimmune, if I suspect that, I would check the hands and peripheral joints, obviously for like swelling, rubor, calor, tumor, and then dive into some deeper associated symptoms. Scoliosis, that's a really quick kind of screen. Just run your finger down the back of their spine. Even if it's not more than 10 degrees to call it scoliosis, you need to know if they have some lateral curvature, because over time, these patients have a higher risk of having stenosis, and they have degeneration faster than age-matched controls. So you want to screen for these patients, and you want to refer them to physical therapy if they do have a little bit of curvature, to make sure they have proper back mechanics to help to support them to be as high functioning as possible for as long as possible. And then again, avascular necrosis, steroids and statins. Steroids plus statins equals, I want to see your hip on x-ray. And if not, I want to see it on MRI. And smoking. So that's a pretty deadly combo. And now I'm going to kind of just review these slides. If you want to take a screenshot or just write it down. Again, takeaways. Point with the finger. In English and Spanish, in any language, point with the finger. Apunta con el dedo. Show me where it is. Stay calm and redirect. Sometimes people might be like, wow, your Spanish is so great. I wanna tell you my whole life story. Redirect. These are, again, the shots, the same slides that we talked about previously, but if you want to take a screenshot, it's here. Again, I just boiled this down to the things that I think are, I need to know the answer to this question when I walk out of the room so I can present. And then next slide. Same thing, put a frame. These are the things that, you know, if it's in the chart, I need to know about it. Or if there's any like shadow of a doubt, I need to ask about it. Because that's the kind of thing that my attending is going to be like, oh, wow, you thought to ask about those things. You're thinking more outside of the box and are actually trying to get to a diagnosis versus just like, she's here complaining this. So just to revise, decide which of these is your patient. Is your patient low back? Is your patient hip? Is your patient leg? Or is your patient everything? And then the new words or the phrases are duele cuando toco, mire hacia el techo, that you can use to get your patient to extend their back. And if you want to be fancy, eso le produjo dolor. Acuéstese boca arriba, or just boca arriba if you want them face up on the table. Obviously, face down, boca abajo. Le duele de adelante o detrás when you're working up hip pathology, and toque sus pies if you need them to flex forward to get some anterior column pathology evaluated. And that is all my slides. So thank you for sticking around. I think I ran over a little bit on time, but if there's any questions, I'm happy to answer them.
Thank you so much, Dr. Mata. That was honestly super helpful and super informative.
Hi, Dr. Mata. This is Luis. I did have a quick question, but first, again, thank you so much for the presentation. I really love the way you put it all together. That was just wonderful. Honestly, as someone who has taught before, this was like put so well for our students. As far as I wanted to ask you about your interest in pain medicine, you know. Is this something that you went into residency knowing that it was something that you wanted to do, or how did you go about exploring the subspecialty during your residency training?
Yeah, that's a good question. I'm always surprised when people tell me like, "Oh, I went into medicine to do PM&R," because I had no idea what PM&R was. Even like coming from a DO school, there's no PM&R like department like attached. So it was all outside rotations. I did an OMM fellowship year between my second and third, which is why I didn't graduate with Deji, although we were in the original class. And I had no idea, but that was basically, they also had us do elective rotations as part of that fellowship. And it was basically like a mini PM&R. We rotated with neurology, with sports medicine, and with pain management. And I just really liked getting to talk to people. I always enjoy that part of it. And then honestly, I do it para los viejitos. I do it for the little old people that want to keep up with their grandkids. And they're like, look at my little granddaughter. She wants to run and I want to run with her, but my back hurts. It's really nice when they come in and they're like, oh, thank you so much. You helped. I can keep up with her now. And, you know, I went back to golfing. Like, it's so cheesy, but I love it. I think it's really important that people can like live their life pain free and feel like normal, like they can keep up with everybody else.
Thank you.
I think we have like 5 more minutes, but if there's like no burning questions, um,
Hey, my name's Vanessa Donaldson. I'm a second year student at OSU College of Osteopathic Medicine, and this was awesome. I feel like so much of what you were talking about brings in the OMM that we're learning right now. So that's super encouraging. I did have one question. You mentioned kyphoplasty and that it was super rewarding. Is that something that you do outpatient, or I'm just not familiar with that particular procedure?
Yeah. So kypho previously was done mostly just by ortho. And there's balloon kyphoplasty and kyphoplasty. If I boil it down, it's basically just you gain access into the vertebral body because it kind of like collapsed on itself. And you either open a balloon or you don't, but you basically fill that vertebral body with cement to kind of give it a little bit of structure so it doesn't keep collapsing. Pain management does that procedure now as well. It's pretty minimally invasive. You can do it like outpatient, like in an outpatient surgical center. You know, they might have someone drive them home. They don't necessarily need to, but it's pretty quick, like less than 30 minutes if they know what they're doing, in and out, and they get better pretty soon. Like as soon as they wake up, they're like, oh my God, that pain is gone. Thank you so much. So yeah, pain management and ortho.
Awesome. Thank you so much. This was awesome.
I had a quick question. My name is Hamad. I'm a fourth year medical student at LeCom Bradenton in Florida. Thank you so much, Dr. Mata. This was a very educational presentation. I really appreciate it. I had a quick question as far as vocabulary for like burning. So you mentioned quema is a good one for burning, or shooting is one where I guess my question is like, how would I describe it if they have back pain that's like kind of going down the leg? How do I say, you know, is your pain going down the leg?
So I like to kind of ask like open-ended so I don't like lead people. So that's kind of why I say el dolor queda ahí o se mueve. Like, does it move? And then kind of let them show me like where it moves. But you could say, just like if you want to keep it really simple, tiene dolor en la pierna. Just, do you have pain in the leg? That's a really good question. And then ask, ¿qué te duele más? ¿La espalda o la pierna? Because maybe they've got myofascial pain or they just have like hamstring tightness. Because a lot of times you do like the straight leg or you do the slump and they're like, oh, it's painful. And I'm like, how is it painful? Aprieta o quema? And they're like, no, aprieta. Okay, so you have muscular tightness. You just have a tight hamstring in the back leg. That's not a positive slump. You don't have like burning pain going into your leg.
Thank you so much.
Yeah. You guys have like really good questions, by the way. I think these are things that kind of like took me a while to like, how am I going to navigate this? And I'd walk out the room and I'd be like, okay, so what did they say? Or like, how does that like in the room, it makes sense. And then as soon as you step out and you have to like present it, you're like, ooh, I don't know about that. So I think one last minute, if there's anybody else.
Dr. Mata, I just wanted to compliment you again that I just really enjoyed this lecture. I really liked the format. I really liked your incorporation of all of the Spanish. I think it was perfect. So just thank you so much for your time.
Thank you guys. I think it's great, like not for nothing, that I really think especially PM&R needs to be like more diverse of a field. So it makes me really happy to see so many people that are like coming up and like excited to it, because you're just gonna provide like that much better care for your patients, and they really, really, really appreciate it. So I think it's great.
Okay, well, muchas gracias. Doctora Mata, muchas gracias por su tiempo. Unless anybody had any last minute questions. I want to be very respectful of everybody's time. I know it is 8 p.m. here at San Antonio time. So muchas gracias otra vez, Doctora Mata. I'll let Digi know that you said hi. And and then everybody else, yeah, have a good night. Thank you so much for attending the presentation, and reach out if you have any questions. Like I said, we're very easy to reach out through our email, but then also through social media and our website. So everyone have a good night, buenas noches, y nos vemos hasta la próxima.